Good afternoon. I'm Dr. Barbara Casper. Thank you for joining us today for Pursuing a Health Equity and Heart Failure live stream. Today's live stream is the final session of the three-part virtual series. Today's discussion will include identification of prevention, screening, diagnosis, and treatment protocols for optimizing health equity and patient outcomes, as well as addressing strategies for eliminating barriers to patient care. At any time during this program, please enter your questions in the Q&A option at the bottom of the screen, and we will have time for attendee questions following the presentations. After you receive a link to a program evaluation, once you complete the evaluation, you'll be directed to a page to claim attendance and credit. If you have any questions regarding logistics, please enter those in the chat. And again, we ask for any questions for our speakers today to be entered in the Q&A section at the bottom of your screen. So it is my complete delight to be able to introduce today's speaker, and that is Dr. Kelly McCants. Dr. McCants completed his internal medicine residency and cardiology fellowship at the University of Louisville School of Medicine, which is where I first knew him, and his heart failure and transplant fellowship at New York Presbyterian Hospital, Columbia University, Irving Medical Center in New York City. Dr. McCants is board certified in cardiovascular disease, advanced heart failure, and transplant cardiology. Before joining Norton Healthcare, Dr. McCants served as the medical director for Samsky Advanced Heart Failure Center at Piedmont Healthcare in Atlanta. Before joining Norton Healthcare, Dr. McCants served as medical director of his role with Norton Health and Vascular Institute. He and his team care for patients with mild to severe heart failure. He also leads the ventricular assist device program and heart transplant access and ongoing aftercare. As executive director for the Institute for Health Equity, he and his team work to address health and racial inequalities in our community by improving access to care in underserved areas, bringing awareness to historical disparities, and anchoring vulnerable neighborhoods with expanded health resources. Dr. McCants has no relevant financial relationships to disclose. At this time, I would like to invite Dr. McCants to begin his talk.
Good afternoon, and thank you for that introduction. I really appreciate you, Dr. Casper, serving as a moderator, but not only that, the work you do for the Institute for Health Equity as well. With that, we'll get started. We can go to the next slide, please. So over this next 45 minutes, we have the charge of moving through three main objectives. Number one would be establishing the current state of healthcare disparities in the city of Louisville. But not only that, seeing how Louisville compares to other cities in the Southeast when it comes to healthcare disparities. We'll also take a brief look at healthcare policies that were instrumental in establishing disparities in certain communities. And then the meat of the discussion will be around cardiovascular disparities within these vulnerable communities and what we can do about them, how the data applies, and really what clinical trials say for those patients that come from vulnerable communities. And then finally, what is Norton Healthcare doing about it? What are organizations that are large healthcare providers? How do you continue to pursue and build around health equity while setting the stage for what other healthcare systems should do in this space? We can go to the next slide, please. And so at the heart of healthcare disparities are historical policies that really put vulnerable communities in jeopardy for social determinants. And redlining was discriminatory practice where certain populations in certain communities were denied investment around housing. And in those communities, we know that housing is directly tied to healthcare. Housing is directly tied to wealth and upward mobility. And if certain communities were denied affordable housing, then we can see that the life expectancy in those communities is different than a life expectancy where affordable housing and the ability to invest was present. You can go to the next slide, please. And so this is simple. We'll look at tree canopy in districts in Los Angeles that were redlined. And if you can read the caption, it just says that we find that socially vulnerable communities tend to live in hotter neighborhoods with less tree canopy. Now, we knew from our early days that trees were important. Trees help produce oxygen and eliminate carbon dioxide. But if you go to the next slide, you can see the inverse relationship, particularly in the city of Louisville, where 86% of African Americans live. There's an inverse relationship between tree canopy or vegetation and air pollution and respiratory hazards and cancer risk. Next slide. And so it is true that if you live in one of these communities, your life expectancy differs by almost 12 years just because of the disparities that have been historically underlined and supported by historic segregation around redlining. You can go to the next slide, please. Here's what we know. In those communities where 86% of the African-American population live, there's challenges in education, there's challenges in income. Of course, there's challenges in transportation or vehicle access. And of course, these are some of the areas that have the highest crime rates in the city. As we mentioned earlier, there are challenges around housing. 70% of the folks that occupy these communities are renters. And most often, 60% of the time, women are the head of the household. When you move eastward, it's usually a two-part family, meaning there's a man and a woman present. But in these communities, the men are often absent and women are the head of the household. The median income is about $22,000. We've talked about the lack of investment around capital and resources. So there's no banks in these communities. One banker for every 1,200 people compared to one banker for every 200 people when you live on the east end of town. And we know that there's food insecurities. And so 2 grocery stores in a 3-mile radius. I think the most concerning part, at least for me, is that when we look in these communities, the utility disconnection rate is almost 40% in a 1-year time. And so if you're an advanced heart failure physician and you have patients on LVAD support, that requires electricity. And if you know that a patient is at a high likelihood of having utility disruption, maybe you would think differently about prescribing an LVAD to that particular patient. In fact, again, when we look at challenges across disease states, you also see it in asthma, diabetes, and mental health. It's okay to advance to the next slide. The point is, in those communities, there's challenges in almost anything that you can measure that becomes a social determinant or chronic disease. Next slide, please. So this phenomenon doesn't just exist in Louisville. I mentioned that you see this across the Southeast, where 65% of the African-American population resides. You can go on to the next slide. So for comparison, let's look at Savannah. In Savannah, with the 2 zip codes that are identified here, 55 to 87% of African Americans reside in those 2 zip codes in Savannah, Georgia. You can go to the next slide. When we look at the health equity report for Savannah, again, much like Louisville, we see that there's challenges in income within these zip codes. The distance to grocery stores is an issue, and of course, food insecurities. You can go to the next slide, please. No surprise that heart disease and diabetes has a higher prevalence in these communities as well. Now, we haven't mentioned anything about a specific patient. We're just talking about social determinants and how being confined to a certain zip code is inversely related or directly related to the amount of disease burden that you have in those communities. Next slide. So again, if you look at Savannah, your life expectancy looks just like Louisville in those areas. There's a decrease of about 12 years if you live in those zip codes. And when you compare African Americans to non-African Americans around hypertension, look at those bar graphs and look at the stark difference in hypertension defined in those particular zip codes. And so And so when we start thinking about what disease states disproportionately affect African Americans, I think Savannah, Louisville, and many other cities that have a high African American population, clearly hypertension is at the root of the cardiovascular disease problem. Next slide, please. So what can healthcare systems do? The reason why we promoted this health equity series is to educate on why Norton Healthcare would be interested in investing in vulnerable communities. Healthcare systems across the United States are well positioned as leading employers and economic engines in their communities to leverage resources to really address these economic, racial, and historical disparities. Next slide. When we look at our community needs assessment, and I reviewed many community needs assessments for many different cities and healthcare organizations, and unfortunately, they all look the same. They all show that access to care is the #1 issue in vulnerable communities. We continue to see that transportation is a problem. I think the most impressive point is that the lack of access to specialty providers, particularly cardiologists, is key in these communities. You can go to the next slide, please. And so when we look at the disease states that I identified, heart disease is at the center, cancer, stroke, and many of the other diseases that we continue to measure and provide treatment for. Go to the next slide, please. A little more. And so when we look at the challenges here, health literacy is at the core, but again, access is what we're talking about. And so this particular demographic slide looks at utilization of Norton Healthcare in the West End compared to the other regions in Louisville. And you can see that when we look at inpatient admissions in the West End, it's higher than any other region in the city of Louisville. When we look at ER utilization, almost twofold in the West End compared to other regions. And we look at outpatient surgeries. So when we see this, it is clear that the data and the need is in West Louisville. And if you're going to dispatch fire engines, you might as well send them to where the fire is. And so when we look at the emergency room visits, for example, we know that if transportation is an issue, then the emergency room becomes that point of contact for your primary care, and we don't want that. You should have regular scheduled primary care visits like everybody else, and the ER should be used for ER purposes, but we don't see that in these vulnerable neighborhoods. Next slide. You can click one more time. Okay, so when we think about the West End Hospital, the entire goal is to increase access and remove barriers. And you can't affect a community without being situated in that community. And so Norton Healthcare is prepared to make the largest site-based investment in the West End in over 100 years. If you go on to the next slide, please. And so in fact, the last hospital in the West End was greater than 100 years ago, and it closed in the 1930s. Now, if you remember what I showed you earlier around redlining and housing challenges, those policies also came into fruition about the same time. So in those communities where we see that there's challenges in housing, to close a hospital at that same time really puts those communities at a disadvantage when it comes to healthcare. Next slide. And so when we talk about this investment, the investment will be a joint collaboration between Goodwill Industries of Kentucky and Norton Healthcare. The total project will be over $100 million. But I think the most important point is that this is an opportunity campus. Not only will we provide healthcare, but there will be an opportunity for workforce development as well at this particular site. So in this hospital, there'll be 20 inpatient beds, a full functioning emergency department, specialty care, including cardiology, neurology, endocrinology, and access to other specialty care, outpatient procedures, diagnostic services. So a full service hospital, we're in a community that needs access. Next slide. And so when we talk about healthcare disparities, Again, access is at the center, but I think no other disease states defines healthcare disparities like cardiovascular diseases. And so we're going to shift to focus on cardiovascular disparities in how not only to diagnose them, but what does the data say for a population that has been historically underrepresented in clinical trials? How do we apply the information that we know to these communities when they haven't been adequately represented? You can go on to the next slide, please. And so I was asked by our marketing lead to give me a definition for health equity. And I struggled with that because it's such a deep definition that once you're in this space, you see that health equity touches every arm of healthcare. And so I came up with this definition that I'd like to read to you. It says, health equity is not about treating all patients the same. Sameness is not equity. It's about identifying and overcoming the differences that may prevent us from achieving the same desired outcome. And so you're looking at pictures here of Dr. Levi Watkins, and you're looking at his picture because he was the first African-American or the first surgeon to implant an AICD. And of course, he's African-American. And as we move through this presentation, you'll see the irony there is that an African-American was the first to implant an AICD, but yet AICDs are still underutilized in the African-American population. You can go on to the next slide, please. And I thought this was interesting. This is the title of this is the quality of care and outcomes for African-Americans with heart failure. Now, the reason why we chose heart failure to underscore what disparities look like is because as far as Medicare is concerned, there are more people admitted and discharged with that DRG than any other group. And so if we don't understand how heart failure affects or how disparities affect patients with heart failure, as an example, then we really won't understand the other disease states. But I thought this was really important because it says that heart failure in African Americans is characterized by variations in history, a lesser response to evidence-based therapies, which underscore disparate healthcare. And I want to focus on evidence-based therapies for just a minute. We can go on to the next slide. And so when we look at the heart failure guidelines, this is a caption that came from one of the earlier iterations of the heart failure guidelines. And it says that heart failure is a prevalent condition in African Americans, elderly, and women. However, in that setting, there is not a lot of clinical data that we understand. And often we paint with a broad stroke the data that we have and say that it applies to all people, when in fact, that may not be necessarily true. We can go on to the next slide. So the paucity of data that exists in clinical trials regarding African Americans in special populations, I think is almost threefold. Number one, there are very few African American physicians in the entire physician workforce. And so when you're trying to consent a patient for a clinical trial and build that trust, if you don't have providers there to explain the importance of enrollment, you're less likely to get an African American or minority patient to enroll in those particular trials. When you look at the number of African American providers that are National Institute of Health researchers, it's about 1.5%. And so again, when you start thinking about who is actually building the trust and asking patients to enroll, there's no African Americans there to really have those discussions. And just to look at the heart failure trials of recent, you'll see that across any heart failure trial, there's less than 10% participation of African Americans in the majority of heart failure trials that are listed there. You can go on to the next slide. And I thought this was extremely interesting. When we look at the participation of Black residents across clinical trials, over 24 cardiovascular drugs that were approved between 2006 and 2020, I think the numbers or the results here are are astounding. You look at Black residents, overall, there were 2.9% of African-American residents enrolled in all FDA drug trials from the period of 2006 to 2020. Next slide, please. You do a deeper dive and you look at the cardiovascular conditions that these drugs were utilized in. It doesn't matter if it's acute coronary syndrome, atrial fibrillation, coronary disease, heart failure, hypertension, pulmonary artery hypertension, or hyperlipidemia. You will see that the participation of African Americans across all disciplines were small. Next slide. And so if you were to look a little bit closer, again, in this particular graph, it's a little bit busy, but it breaks down each particular drug. And I won't leave this up here alone, because the whole point of this is that when you look at enrollment by race, less than 3% for acute coronary syndrome for African Americans, for atrial fibrillation, less than 1.2%. And I could go on and on and on, but I think the next slide really paints the picture. When you look at participation to prevalence of disease, and you go from 2006 to 2020, you can see that these particular curves continue to diverge. So it's not like we're getting better with participation in clinical trials for African Americans and other underserved populations. We're actually getting worse. And so there's a ton to do around education, awareness, and understanding that if you don't have participation in the trials, you must be careful with your recommendations regarding medical therapy. Next slide, please. And so this is a paper that we published greater than 10 or 15 years ago. And when I understood that there wasn't a lot of representation for African Americans in clinical trials, I wanted to figure out what we could do at the University of Louisville at that particular time. What I was noticing is that African Americans, when they presented to our heart failure clinic, were worse than their non-African American counterparts at the time of presentation to a heart failure provider. So that means at the first encounter, they were often worse in their disease state than their non-African American counterparts. Can you go to the next slide, please? And so quickly, we reviewed charts from 2006 to 2013 for all patients that presented to our clinic. You can go to the next slide, please. And here's what we found. African Americans tended to have a higher BMI. They tended to be non-ischemic as the etiology of their heart failure. Hypertension tended to be at the core of the etiology for their heart failure. When we look at the medications that we knew improved morbidity and mortality, hydralazine and isodil, which had astounding results in the AHAF study, 43% reduction in morbidity and mortality, were less likely to be used at that particular time. But I think the most depressing point is that at the time of presentation, African Americans tended to have RV dysfunction at the time of presentation to a heart failure clinic. And now, if you're in the advanced heart failure space, you know that the right ventricle is the Achilles heel for advanced heart failure. And these particular patients at presentation, didn't matter the age, already had RV dysfunction at the time that they presented. Next slide. And so if you were to read any heart failure guidelines, it would have you believe that heart failure is a disease of older white males. And I will tell you that in the city of Louisville and in many of the cities in the Southeast, that is not the adequate representation for what heart failure looks like. And so when we look at this data, this is Norton Healthcare data over a 3-year period of about 13,000 admissions with a diagnosis of heart failure. And you can see in younger age groups, heart failure reflects more of a female representation than male. As you get to older age groups, again, more female representation than male. But what we do find is that in the city of Louisville, African Americans make up about 17 to 20% of the population, but make up about 40% of all admissions for heart failure under the age of 40. And so if you're waiting to be counted in the Medicare population of 65, you're missing a large group of African Americans because they often die before they make it to that 65 age group to where they could be counted in a Medicare population. Next slide. And so this is something that we presented at the Association of Black Cardiology in 2020. You can go on to the next slide. And I think this case really sets the stage for the rest of the discussion and what I want to talk about. And so when you look at this particular case, if you're a cardiologist on this particular live stream, or if you are an internist, the first thing you look at is you say, wow, this heart looks like a basketball. And of course, you see severe mitral regurgitation. Now, if you look at the clinical history that I provided, you'll see that the EF is down, the ventricle is dilated, there's evidence of neurohormonal embarrassment with a creatinine of 1.5. But I can tell you that's not the most important predictor of what we're going to do with this patient. The most important predictor of this patient's survival is her zip code. She comes from the California neighborhood, which is one of the most vulnerable communities in the state of Kentucky. And so this patient, based on their clinical data, you can go on to the next slide, it's okay. Based on the clinical data, would suggest that we put this patient on an inotrope and refer this patient for transplant. Well, putting a patient like this on IV Mironone is not really the best option. When you live in certain neighborhoods, there's a challenge with getting home health to go into the home and infusion therapies. Again, we talked about transportation being an issue. If you're on inotropes, you need to have frequent follow-up with your advanced heart failure team. And that's really not the best option for this particular patient. We'd like to refer this patient for LVAD or transplant, but we talked about the ability of the likelihood of utility disconnection rates in that community. So that's not the best option. And of course, for heart transplant, not only do you need frequent evaluations and clinic visits, but you also have to have insurance. And so unfortunately, a patient like this will just be maintained on oral medical therapy and monitored as an outpatient. Next slide, please. And so when you review the database around LVAD implantation in patients across the United States with advanced heart failure. So the American Heart Association in 2019 had a registry that looked at about 90,000 patients that resulted in 3,700 LVAD placement. And I'll get to the point. If you were African-American, you were 28% less likely to receive an LVAD. If you were Hispanic, you were 38% less likely to receive an LVAD. And it came down to this: patients residing in the lowest zip codes were less likely to receive care for advanced heart failure. Next slide. Not just LVADs, we see the same thing with transplant. Usually if you're African-American, by the time you make it to the transplant list, doesn't matter if it's heart or kidney, you're usually sicker at the time of transplant, would have higher mortality while you're waiting on the list. You can go to the next slide. And then here's the irony. The first heart transplant was done in 1967, and the assistant was a Black surgical assistant. And again, even though the therapy you could say was co-invented or co-performed in the 1960s by a person of color, still the application of the therapy doesn't reach that particular group. Let's go on to the next slide, please. And so we see this, and I love this title. I won't read what this article is about, but equity in heart transplantation allocation is important. And if we don't get ahead of this, we know that the #1 predictor of being on a transplant list is having insurance and access. And so you can imagine if you don't have either, you're less likely to be transplanted. Next slide. And if you are transplanted, if you're African-American, the studies show that you're most likely to be transplanted at a lower performing center. Next slide. And so we'll transition to sudden cardiac death. And I love this particular caption that I put together with Red Fox, who was the greatest comedian of all time. But Red was always saying that he was going to die of a heart attack. And so when you start to look at sudden cardiac death, and this study came out of Pennsylvania, it says sudden cardiac death behaves differently in different groups. In fact, on autopsy, as this study is supporting, if you were to do an autopsy on patients that died of sudden cardiac death, most times if they're African American, you will find that coronary disease was not the reason they died of sudden cardiac death. Even though they had a myopathy, it was usually non-ischemic myopathy on autopsy. You can go on to the next slide. Now, for me, this is a little bit challenging because we were always taught that historically that AICDs, of course, are important for anybody that has LV dysfunction, but across disciplines, more people that have ischemic heart disease tend to be protected than non-ischemic. Well, for African Americans, they're more likely to be non-ischemic and have a higher rate of sudden cardiac death. And I think the conclusion of this particular study says it best. Income, education, and traditional risk factors explain 60% of the difference. Well, your income and your education should not determine your likelihood of dying of sudden cardiac death. It should be the disease state that you have. Next slide. And so if you ever get a chance to pull an article, I think this article is one of the most relevant articles in disparities as it relates to cardiovascular care. The senior author is Quinn Capers. He was at Ohio State, and I think now he is at a different institution in the Southeast. But Dr. Capers was also a cardiologist, and he did a phenomenal job identifying the lack of application of therapies that improve survival in African Americans in the cardiovascular space. So you can go to the next slide. When you dive into this, and let's just take AICDs, revascularization of lower extremity and percutaneous revascularization as a subject matter for this particular slide. You can go to the next one. So when you look at the application of AICDs, and if you have an AICD, the ability or the application of CRT in that setting, which is optimization of the AICD so that both ventricles contract at the same time. And if you look at number 3, reperfusion therapy, or reestablishing blood flow in your coronary system or your lower extremities, it is clear that across all 4 of these therapies, African Americans were less represented. You can go to the next slide. A lot of words on this slide, but in yellow, we see that it doesn't matter if you're at an academic center, a community hospital, or a private hospital. Black patients were less likely to receive an AICD despite an increase in AICD therapy as time progressed. And when you start to look at quality programs like the Guidelines, this also became an issue when you went back to look at the quality and the application of these therapies across all disciplines. Next slide. And so that was a study that looked at national application of AICDs. And so what I wanted to do is look at the utilization of AICDs in Jefferson County. And so this slide is a little bit busy, but that top half looks at a 20-mile radius in Jefferson County. Again, you can look at that bump where I identified the disparities are. But when you first draw that 20-mile radius, it will tell you that heart failure is more prevalent in white Americans in the city of Louisville. When you reduce your scope to a 5-mile radius, the demographics almost flip. And because again, 86% of all African Americans live within that 5-mile radius where we put the dot here for this particular demonstration. Next slide. And so if you look at rhythm management procedures and the treatment rate, and I want to take time to read this particular caption. It says inpatient and outpatient treatments. The bar chart on the right outlines what the current treatment rates are in the hospital and what future treatment rates would be if all other demographics were treated at the same rate as white males. And you see that the treatment rate for white females was about 486, but there's an opportunity for about 300 more particular patients. And then when you look at non-whites, particularly African Americans, the opportunity was about for 428 more patients on an annual basis if the utilization and treatment rate compared favorably to other demographics as it did to our white counterparts. Next slide. Say it in a different way. The likelihood that you will receive a management device if you have advanced heart failure in the city of Louisville is about 10.3%. If you're African American, it's about 2%. And so when you start to look at these disparities across AICD utilization, it really underscores the opportunities around awareness for cardiovascular diseases in the city of Louisville. Next slide. All right. And so our interventional cardiologists can't escape disparities as well. This particular slide says that African Americans were 33% less likely to receive a diagnostic heart cath. And even if they found areas that needed to be intervened, they were 42% less likely to undergo percutaneous intervention. Let's take it a step further. Even if you had a stent placed, there still was lower rate of utilization of a drug-eluting stent and the use of dual antiplatelet therapy. And so we really have some opportunities in the cardiovascular space. And I think as I was researching this, the same theme continues to go over and over and over again. In the cardiovascular space, we have some clear opportunities around healthcare disparities. Next slide. Now, this is also a little bit busy, but if you look at what we have here, in the top part of the graph, you have percent of patients with coronary artery disease. And on the bottom, you have percent of patients with hypertension based as a etiology for their heart failure. African Americans are represented in purple. Sorry, African Americans are represented in the red color. Non-African Americans are represented in purple. To make this as simple as possible, it says if you're African American and you have heart failure, when you look across every heart failure trial, it is clear hypertension was the leading etiology for your heart failure and not coronary disease. And so if you have a young African American patient that presents to your office with LV dysfunction, the guidelines would say that you should do a left and right heart cath to evaluate the cause and etiology of that heart failure. I would say be a little bit cautious, particularly if that patient is young, under the age of 40, has significant LV dysfunction, and if the kidneys are not normal. You don't necessarily want to do a left heart cath first when hypertension is likely the etiology in that particular patient. Next slide. So when we look at cardiac surgery in African Americans, and you can advance to the next slide here, when we review the STS database, and I'll go very quickly here. So in 2003 or 2005, whichever we pull this from, you'll see that there are almost 600,000 patients underwent cardiothoracic surgery, 25,000 were African American. If you look at the demographics represented in table 1, let me make this very clear for you. When you look at the risk factors for diabetes, African Americans were almost twofold likely to have diabetes. They were almost threefold likely to have renal failure and almost fourfold likely to be on dialysis at the time of cardiac surgery. Well, we know that patient selection is key to desired outcomes in cardiology, but African Americans are usually presenting worse at the time of surgery with a higher case mix index. Next slide. All right, looking at lower extremity ischemia in patients with PAD and how we reduce the quality of life. Well, you understand here or how we improve the quality of life. But if you look at these 19,000 patients, it's clear that Black patients were 2 times as likely to undergo above the knee or below the knee amputation as opposed to revascularization strategies that could be limb preserving. So across almost every discipline in cardiology, again, we see that these disparities continue to unfold. Next slide. Okay, and so the summary of that particular article, there were a lot of summaries or opportunities that Dr. Capers pointed out, but I want to highlight the one that I think is most relevant. It says the physician workforce in the United States does not reflect the nation's patient population, and potentially exacerbating all the above and depriving many patients of culturally sensitive and compassionate care from individuals with whom they have something in common. And that is the entire point of what we're saying here, is that if you're going to build trust, sometimes it takes someone that has the same cultural sensitivities that you have. Sometimes it takes people that look like you in order to get the message across. Next slide. And this particular study gets right at that point. It says that those patients that saw Black doctors received 34% more preventative care than those that didn't. And it's not that Black doctors are the best doctors. It's that patients that had trust issues identified better with those particular doctors in the cardiovascular space. Next slide. But here's the challenge. When we start to look at training programs and the ability to graduate cardiology fellows, you'll see that 4.3% of all cardiologists are African American. And in the city of Louisville, we're looking at about 3 cardiologists that are African American. And so the whole point is, if we're going to, in fact, impact patient care, get around trust, then pipeline is important. We must make sure that we have providers that are diverse and mirror the communities that we serve. Next slide. And here's why we don't have a lot of Black doctors, at least this is one of the points. And so if you're familiar with the Abraham Flexner report, you will understand that it did one amazing thing. It was truly transformative in how medical schools provide education. However, it also had some unintended consequences and closed about 75% of all medical schools in the 1900s. You can go to the next slide. Using Johns Hopkins as the ideal institution, Abraham Flexner said that if we're going to revamp how we do medicine, we must make sure that those going into medical school have an undergraduate education. Medical facilities have laboratory abilities, not as well as strong clinical instructors. And all these are good things. However, at the time, this closed almost 90% of all African-American medical schools that were graduating Black providers. Next slide. And in fact, in 2008, the American Medical Association issued a formal apology for its role in historic racism as it relates to African-American physicians. Next slide. And you see the same throughout other clinical providers in terms of APPs, physician assistants, and pharmacies. Next slide. All right, and so we're almost done. I want you to take away this particular key point. When it comes to health equity, your socioeconomic status is the most powerful predictor of disease, disorder, and injury and mortality that we have. You can go to the next slide. And so when we're thinking about how to engage our patients around patient care, and I like this example, still going back to sudden cardiac death, it says these findings suggest the possibility that when it comes to prevention of sudden cardiac death, which you can insert any of those other disease states that I highlight, different races and ethnicities may not be necessarily painted with one broad brush. And I think this is at the heart of patient care. You can go to the next slide. And this is at the heart of what we must do when our patients are in front of us. And so I'll pause now. Sorry, so long-winded, but take some time for questions.
Thank you so much, Dr. McCants. That's an excellent review of how we got here and hopefully how we can move forward. I have a couple of questions, and then there was a question in the chat. The first question I have is, it is very clear that once people reach the point of having end organ damage from their hypertension, that the disparity is massive about their access to care and how they're treated. What are you, and I'm aware of some things, what are you all doing to try to address the hypertension issue in this community, to try to prevent them from getting to the point? The question I have is about the obvious disparity in the African American physicians in the community. And I know that Simmons has been given some money to help with that. But what do you think that's a long process, right? To go from starting there and getting people through medical school and residency, as we both remember, that was not in a short window of time. So what do you anticipate that looking like, and what's your timeline for that?
Sure.
Then I
So,
will get the Q&A.
sure. So that was a big question. Let me try to break that down into parts. The first thing is that we know if there's a single thing that we can change or impact, it would be preventative care around hypertension. If you're an African American with hypertension, obviously the target of 120/80 is what we're shooting for. But understand that hypertension in African Americans happens about 15 to 20 years sooner than we think. And so I know our community medical directors have been very involved with educating the community, Dr. Patton, Dr. Narcisse, Dr. Noda, but Dr. Patton is launching a barbershop campaign to make sure that we go out and provide education and awareness to barbershops within the community and trusted facilities, not just barbershop, but the churches that you identified. St. Stephen's and Bates, we have programs there where we've given support around education, awareness, and clinical programming. Again, we're 100 years behind time. And so the more people we can educate as ambassadors to what we're trying to do around healthcare and hypertension is key. And so, live streams like this is extremely important. Having the Health Equity Institute located at 12th and Jefferson is important as a way of convening with the community around preventions and screenings. We're out there doing as much as possible to make people aware. But I think the most important point is, you have to reinforce lifestyle changes. The diets are not what they should be. The exercise is not what it should be. And young people don't like to take medicines. And as we pointed out, African Americans tend to be younger at their diagnosis. But if we're going to prevent end organ damage, we have to build that trust, have people understand that medications are important, and frequent follow-up.
So another question we had was that, while placing a healthcare facility in the West End is great and people can access care, that the concern is that, are they going to be able to pay for treatment, and how is Norton going to work with them? That's one piece of it, but when you're in a economically disadvantaged area, the treatments are very expensive, the medicines are expensive, and so how is Norton going to help, potentially address that?
And another big question. I think very carefully is the answer. The first thing is you have to be there, and so the biggest way to address that is that we will be in the community. So that will hopefully help, I don't want to say eliminate, but alleviate transportation as a barrier. With our community health workers, with our Unite Us platform, all the resources that we have now, patients will have access to ways to get those resources to support not having finances, insurance, or what have you. In disadvantaged areas, we're often dealing with Medicare, Medicaid population. And so working with Medicare, Medicaid, and the folks that administer those policies locally to make sure that we collaborate with their community health workers and the resources that they're utilizing to make things affordable. And so I hope that's the best way to answer that question. Of course, we don't have universal healthcare in the states, but we can start by being there and linking people to resources. I think is the best thing that we can do.
There was another very interesting question about since this is a problem in other communities, do you have any information about how it's being addressed there and any successes that possibly could be applied to what we're doing here? So for example, in Savannah, if they're addressing that health inequality, how is that working? Are there successes, and how can we actually hear?
So let me say things this way. When I visit these areas that we talked about, I talked about Savannah, but you see the same thing in Knoxville, Chattanooga, in many of the cities that I've had the opportunity to visit and give presentations in. It is clear what we're doing in Louisville. We are a few steps ahead of what other cities are doing around health equity. And that's largely because of Norton Healthcare's investment. And I don't say that in an arrogant way. I say that in a way that we are committed to our mission, vision, and values. And there's challenges in other cities in that they may not be the largest healthcare provider in their city. And so often trying to operate in silos and do things with other institutions to bring about population change is an issue. But here in Louisville, Norton is the largest provider. And so we have the largest accountability. And we have taken the charge to set the blueprint for how other organizations respond. No, so it's not that, we won't take things that are being done right in other cities and use them in our playbook, but we're really leading the charge as it relates to health equity.
Are there any other questions? No, if not, I think that was an excellent presentation, and I applaud your and Norton's commitment to really trying to fix this problem. It's going to take a while, but I know that with your leadership, it's going to be done.
So if I could just offer a final comment and a final thought. Sometimes talking about race in healthcare is a little bit uncomfortable, but the more that we know, the easier it becomes. And I think if we keep the patients at the center of everything we do, it really makes things easier. But kudos to our administration and our leadership team for setting the organization down this pathway. I may lead the Institute, but there is a whole team of folks that understand the importance of health equity across disciplines. And so you have the Health Equity Institute, but you also have Norton Medical Care, you have the NNI, you have NCI, you have the marketing team, the community medical directors, community health workers on the adult and pediatric side. And so it's going to take a true village for us to move things in the right direction. As I identified before, some of the policies that set us down this pathway are 100 years old. And so some of the changes we put in place, if we start now, we may not see the benefit for several generations. But at least I'm so excited that our organization is leading the charge and starting right now. So thank you for your time. Thank you for your support. And hopefully you were able to take something away from this presentation.
Thank you.